It's a clinical approach on optic neuropathy. I request Dr. Ramya, my co-instructor, to come here on the dials. I request Laila madam also to come over. So as we know, optic neuropathy is such an important topic. A damage to the optic nerve, a dysfunction to the optic nerve has different approaches depending upon what cause leads to it. So that is why, and as general ophthalmologists, we do find many cases like this, and we do have different approaches for all these. So let's start off. Our first speaker is Dr. Ramya. She will be talking on optic neuritis. She is a pediatric ophthalmologist from Cooperative Hospital, Payyanur.
Okay. Good morning. So I'll be talking on optic neuritis. Optic neuritis as such is an inflammation of the optic nerve. So it's a demyelinating inflammation of the optic nerve. There are many causes of optic nerve inflammation. So typically we'll be dealing with demyelinating inflammation of the optic nerve. So optic nerve can get affected from any part of its course. So it can be intraocular till the chiasma optic tract. So when it is intraocular, you call it as a optic disc edema papillitis. But if it is behind the optic disc, you call it as a retrobulbar neuritis. Okay, so let me start with a case. This is a 44-year-old lady with loss of vision in the left eye in one day. She had pain on eye movements. There was no other neurological deficit. Vision was 6.6. Left eye vision was counting finger 1 meter. Anterior segment examination was normal except for a grade 3 RAPD. And this was her fundus. Everything normal. And the field effect shows generalized depression in the left eye. Otherwise, right eye was normal. So considering this, we will call it as left eye retrobulbar optic neuritis. So we have sent the patient for an MRI orbit with the gadolinium contrast and fat suppression. So you can see there is an increased intensity in the left optic nerve, and which is enhancing in the contrast. So this is an MRI brain normal. So this is a case of isolated demyelinating optic neuritis. There are no MRI brain lesions. Okay. So we gave a treatment of IVMP 1 gram daily for 3 days, followed by oral prednisolone 1 milligram per kilogram for 11 days and a short-term taper as according to our ONTT trial. And after 3 weeks, she started improving her vision and color vision. So why we should do MRI brain? Because optic neuritis is present in 50% of cases with multiple sclerosis, and 20% multiple sclerosis optic neuritis is the presenting feature, and it is the strongest predictor for clinically defined multiple sclerosis. So the lesions in the multiple sclerosis in brain can be periventricular, juxtacortical, subcortical, or infratentorial as in cerebellum. So typically what you get this type of lesions in the periventricular area is called as a Dawson's fingers. So why it is important? Because if there is no lesion in the MRI, there is only 25% risk of MS in the next 15 years. Whereas if you have one lesion, 60%, 2, 68, and 3, 78. It keeps on increasing. So there is a devised McDonald's criteria. I am not going into the details, but you should know two terms. That is dissemination in space and dissemination in time. Dissemination in space means you have different lesions in different locations. Whereas in different dissemination in time means you have lesions of different ages. The previous MRI can be normal and a new lesion appears. Or in the same MRI, there is a lesion which is enhancing, one which is not enhancing. That is suggestive of an old lesion. So when you call it typical optic neuritis, either it is an isolated or it is associated with a multiple sclerosis. So the characteristic features are it usually occurs in young or middle age with a female preponderance, acute or subacute loss of vision associated with pain and decrease in color vision and contrast. So vision, not only the visual acuity, you should also check the color vision, especially the red desaturation and contrast sensitivity and visual field. So visual acuity, it can be 20/20 to profound loss of vision, that is no PL. So you should get all the other tests also get done. And visual acuity, it reaches a trough in the first week, then it starts improving by second to third week, comes back to almost normal by 4 to 5 weeks, then over the next few months it comes back to normal. Okay. Then the color visual field, it can be from a normal field to a diffuse loss or an altitudinal field loss, central scotoma, centrocecal scotoma, or anything can happen in visual fields. And pupil, normally optic neuritis is unilateral, so you will get a RAPD. And visually evoked potential, you will get an increased P100 latency. So there are some phenomena associated with this optic nerve. One is Pulfrich phenomena. What happens normally when a pendulum rotates from one side to another, it moves in a linear fashion. But if you have an optic neuritis, what happens is there is decreased conduction on one side. So the patient will see a parabolic effect rather than a linear thing. Okay. Then Pulfrich phenomena I have already explained. Next is the Lermit-Sen. So sudden flexion of the neck that will cause an electric shock like sensation. And Uthoff's phenomenon, the increase in body temperature leads to decrease in visual acuity as at the deepening of the scotoma. These are more associated with the multiple sclerosis than an isolated optic neuritis. And this is your landmark study, ONTT trial. So here we have 3 arms, IVMP, oral steroids and placebo. So even if you don't treat or you treat, the ultimate visual acuity will be normal in any case. But why you should treat? That answer comes from the ONTT trial. Because the visual field and visual acuity recovery is almost same in all cases. But what you should know is the probability of recurrence of optic neuritis is maximum with oral steroids. And the clinically defined MS in the first 2 years is minimal with the IVMP. So that is why you should treat with an IVMP. Because it will not affect your vision as such. So how can we alter the disease course? So these are the different drugs used. So if you treat your MRI lesions, you can definitely prevent or delay the development of multiple sclerosis. I am not going into the study. These are the champion study and all these compare the drugs. Okay. So now let me come to the second case. This is a 21-year-old boy, sudden loss of vision in the right eye for 4 days. There was pain on eye movements. And when probing, he gave a history of similar episodes. And the second episode, he had vision first affected left eye, followed by the right eye, and he was started on IVMP and azathioprine. And now when he showed me, he had his right eye was affected. So his vision was counting finger, grade 3 RAPD with a disc pallor in the right eye. And the MRI, I don't have the picture, sorry. Thickening of the right optic nerve extending to the optic chiasma. You should note that it is extending up to the optic chiasma. It's a long lesion. And even in the left eye, there was non-enhancing hyperintensity suggestive of a previous attack. So this was his fundus. The right eye shows a disc pallor and the right eye has a field defect. So what is atypical in this case? One thing, it is bilateral. There was history of recurrence. And another thing was, whenever he was on steroid, whenever his treatment is reduced, he again gets the symptoms. So there was a steroid dependence and pain was lasting for more than 2 weeks. So atypical optic neuritis, you should suspect when the age is less than 12 and more than 50. If there is bilateral involvement or recurrence, progressive vision loss for more than 10 days, steroid dependence, severe disc edema, lack of pain or pain lasting more than 2 weeks, or associated with the constitutional symptoms. That I will come to later. So we have two main types. This is the NMO, that is neuromyelitis optica, and the MOG, myelin oligoglycoprotein. So how you differentiate these three, I will just tell you. In multiple sclerosis, you will get a short segment involvement in an optic nerve. And the upper part of the spinal cord is involved. Sorry. Upper part of the spinal cord is involved and it is short segments. And in the brain, you will get a pericortical involvement. Whereas in MOG, the perineural sheath involvement is happening and the chorda equina part, it is more in the lower part, and you can get area prostrema involvement. Whereas in NMO spectrum disorders, you can get bilateral involvement, long segment involvement, chiasmal involvement, even up to the optic tract. And not only the white matter, even the grey matter can also get involved. You can see the central and as well as the peripheral, and it involves the cervical and thoracic part. And wherever the aquaporin 4 antibody is there, all these parts can get affected, and that's why leading to symptoms like vomiting, nausea and narcolepsy. So you should ask these symptoms in these patients. So I'm not going into the details, and in atypical cases you should ask for, send for all these antibodies, and this is how you treat. If you have a typical patient, send for MRI brain and orbit with fat suppression and gadolinium contrast, IVMP and oral prednisolone, treat for MS depending upon the MRI brain lesions. If you have atypical lesions, NMO, MOG antibody, LP, brain orbit and spine. And IVMP followed by oral prednisolone, plasmapheresis, long-term immunosuppression. This is all what I told today, how to differentiate between NMO, MOG and multiple sclerosis. Thank you.
Thank you, Dr. Ramya, about optic neuritis in such a short time. I think we'll have the discussion at the end of the session. Next, we go on to the next speaker, Dr. Ghana Ajoy. She is going to talk about ischemic optic neuropathy. She is working as a senior vitreoretinal surgeon in Dr. Rani Menon's Max Vision Eye Hospital, Thrissur. Over to you, Dr. Ghana.
Good afternoon. So my talk today is ischemic optic neuropathy, and I'll jump right into it. So ischemic optic neuropathy is infarction of any portion of the optic nerve from the chiasma to the optic nerve head, and it is a microvascular ischemia, and it is acute in onset. So when we look at ischemic optic neuropathy, it can either be anterior or posterior, and how do you distinguish that? The presence of disc edema points to it being an anterior one. It can be arteritic or non-arteritic, and absence of disc edema can point to a posterior, which can be arteritic, non-arteritic, or perioperative. So anterior ischemic optic neuropathy refers to ischemia of the optic nerve head, and posterior or PION refers to ischemia of the posterior optic nerve. In terms of blood supply, if you look at the optic nerve head, it is primarily supplied by the PCA, or the posterior ciliary circulation arteries. So it is basically a segmental distribution. This causes a sectoral blood supply to the optic nerve head and explains a segmental visual loss in AION. Embolic disease is rare. This is because of the small size and the extensive anastomosis of the vessels that supply the optic nerve head. Whereas a posterior ischemic optic neuropathy has no specific location, any part beyond the ONH up to the chiasma, and there is no specific definite artery to pinpoint. So let's get into a case. A 50-year-old gentleman, he presented with defective vision in the left eye of 2 weeks duration. Vision is 636 in the left eye and right eye is 66. He's a known hypertensive. The right optic disc has minimal cupping and it is a disc at risk. And the left shows a segmental disc edema. It is hyperemic. There is dilatation of the superficial disc capillaries. So normal visual field in the right eye and altitudinal visual field defect in the left eye. No CT shows swelling of the peripapillary RNFL in the region, in the inferior region without macular involvement. This is non-arteritic AION. This is greater than 85% of all cases. It is an idiopathic process, around 60 years, but can be younger than 50. Primarily a clinical diagnosis. Anterior to the lamina cribrosa, so we have to see disc edema, and occurs in small crowded disc or disc at risk. If the patient is very young, has glaucoma, has a bigger cup disc ratio, there is no REPD, there is cupping after an episode, and there is no disc edema, it cannot be an AION. Look for another cause. If there is too much of everything, that is disc edema or exudates or hemorrhages or even fluid, it is not an AION. So it is basically a compartment syndrome where the ischemia of the ONH from the hypoperfusion leads to edema, obstructs axoplasmic flow, again leads to edema, and then causes further compression of the circulation. It's a vicious cycle. The established risk factors are hypertension, diabetes, hypercholesteremia, optic disc morphology, and perioperative visual loss. And the late findings include disc pallor and corresponding nerve fiber thinning and macular ganglion cells loss. This is seen on OCT. FA shows initially a poor filling of the disc and the peripapillary choroid with late focal leakage. Primarily, as I've said, a clinical diagnosis, all the others are just contributory. If he has a typical risk, typical history, nothing else other than management is required. If they are atypical, further workup is required. So that includes ESR, CRP platelet counts, MRI, ocular imaging, and if younger than 50, also look for hypercoagulable states. There is no medical or surgical treatment. Aspirin does not help. Corticosteroids reduces the edema fast, but no significant visual gain. Bevacizumab again reduces the disc edema, but no visual gain. And optic nerve sheath decompression has no role. So no consensus also on the percentage of cases that will deteriorate or improve. So coming to the next case, which is a 68-year-old lady who presented with defective vision of the left eye 1 week onset, visual acuity 360 in the left eye, and right eye was 160. She has a mild headache but no eye pain. Has an altitudinal field loss. The fundus shows a pallid, severe disc edema. Small hemorrhages near the disc margin are there, not seen very well, but it is there. And the fundus photograph, as I've said, demonstrated this, and the angiogram shows an optic disc leak with patchy filling of the choroid. OCT again shows RNFL edema. ESR is 60 elevated, CRP is elevated. Considering a temporal artery biopsy at this stage, unfortunately at this point she has an ASOM, she has a mild fever. We are waiting 24 hours at this point. Beyond 24 hours, we've started on IV methylprednisolone, continued on oral steroids. She did well, but visual improved to 612, but disc has gone for pallor by that time. So this is a case of arteritic AION. So GCA, until proved otherwise, it is almost always associated with GCA. It is more widespread. There is no examination feature to rule out GCA per se, but the stakes of missing this are very high because the fellow eye will get involved within days even. Stroke, aortic dissection, myocardial infarction are other life-threatening complications. There are criteria: age greater than 50, new headache, temporal artery tenderness, elevated ESR, and biopsy. Visual loss is the main thing. It mostly AION and arteritic is the most common cause. Headache is the most common symptom, and jaw claudication is the most specific symptom. Elevated ESR and CRP are seen in 85% sensitive for the presence of GCA, but 10% may have normal values. The gold standard is a positive temporal artery biopsy. MRI and Doppler ultrasound help us, but they are not definitive. Management is steroids, 3 days of high-dose IV methylprednisolone, continue with oral treatment, tapering over 1 year slowly, and now we have tocilizumab, which is FDA approved for GCA. Coming to posterior ischemic optic neuropathy, unilateral or bilateral neuropathy of vascular origin, no disc edema, disc appears normal, RAPD is present. In patients who have undergone, it occurs in patients who have undergone prolonged, especially spinal operations. As an uncomplicated complication of GCA, it can occur, and in a non-arteritic form, it is usually associated with vascular risk factors. It is hard to identify, but it is always a diagnosis of exclusion. You have to do all the investigations, rule out arteritic causes, rule out other compressive lesions, but there is no therapy as such. The key is limitation of risk factors and treatment of GCA. Now coming to this particular gentleman, who is a 51-year-old gentleman with best corrected visual acuity of 6.6 in both eyes. Defective vision, came to us with defective vision in both eyes. Diabetic of 10 years duration. And this is the picture. He has both eye disc edema, sectoral in both eyes. It is not very well seen in this particular image, but the FA, as you can see from the right eye, initial hypoperfusion with late leak and even perifoveal leaks, macular leaks. This was in 6th May. The left eye also showing a sectoral or a segmental disc pallor, disc edema with late leaks, far more on the left eye. He also has associated new vessels. So this is both eye NAION with HRPDR in both eyes. This is on 8th May. He undergoes PRP in both eyes. Then 2 months later, he has drop in vision in both eyes. Right eye has dropped to 6.6 parts N8 and left eye to 636 N24. The disc, and now there is macular edema as well. This is after 2 months of treatment. That is laser. And he was given injection of Avastin in the right eye on August 19th and left eye on 26th. By October, his vision has come back to 6.9 in the right eye and left eye 6.6. And this is what the fundus looks like. There is the presence of membrane because there was NVD along with this. In both eye, there is epiretinal membranes, and this has become pale. Left eye sectoral, right eye, a great proportion of the disc is involved, disc pallor. So diabetic papillopathy. What is diabetic papillopathy? It's presumed to be the result from diabetic microangiopathy, and this theory is supported by abnormal disc surface staining and fluorescent leakage found on FA. There are no pathological studies to confirm this theory. So is it NAION? Is it not NAION? The tug of war goes on. I consider it part of ischemic optic neuropathy and treat it as such. So to conclude, NAIN is the most common non-glaucomatous optic neuropathy in patients older than 50. No proven treatment to improve visual outcomes. Arteriatic AIN is a medical emergency, and nearly all are due to GCA. Thank you.
Thank you, Dr. Ghana, for those discussions on dilemmas in ischemic optic neuropathy. Now we move on to compressive optic neuropathy by Dr. Soumya Nambiar. She is a consultant in pediatric ophthalmology department in Comtrust Eye Hospital. Over to Dr. Soumya.
Thank you, madam, for the wonderful introduction. And good morning to everybody. So today morning we have been dealing with a lot of optic neuropathy cases. So when it comes straight on to you, you are basically confused. Oh man, what is this disc edema? What is it now? Is it an NAIN or is it an optic neuritis? That is the first confusion that occurs when a patient comes to you. This topic, when you are talking, it is theoretically very okay. But when the patient comes to you and presents to you, it's totally a different scenario. So today I'm going to talk about compressive optic neuropathy. So what do you mean by compressive optic neuropathy? It is a damage to the optic nerve by pressure within the optic nerve or from nearby structures. So it could be a compression, as I said, because of an intrinsic cause, or it could be due to an extrinsic cause. Okay. So how does the damage occur? It could be because of the direct pressure because of the mass. It could be because of the vascular compromise because it's compressing on some vessels, or because of axonal damage. So before knowing where, you know that this compression can occur in different parts of the optic nerve. It could be the intraocular, intraorbital, intracanalicular, or intracranial. Intraocular or something very near to the eye, definitely you may not miss it because it will present with a disc edema, but something behind, that is when you have to be very cautious, right? So to just give you a picture of this is a cadaveric dissection. You can just see how the optic nerve is. That's the eyeball, which you can see. I don't know if you can see my pointer. Okay, so you can see the optic nerve and just see the vessels that is around. You can see the cranial nerve 3, the 6, and the muscles. Any infection, any mass in these areas can lead to compression. Okay, and this is a dissection in the intracanalicular part. So you can see this optic nerve which has been dissected here onto your right side, and you can see the ophthalmic artery just beneath and an internal carotid artery. So this bony, it's a just small canal, the intracanalicular part, and radiologically, every chance of missing this lesion, even radiologically. Okay. This is to emphasize how the optic nerve is joining the optic chiasma. You can see the pituitary gland just beneath, and any tumor there can cause compression on the optic nerve or the optic chiasma. And this is the coronal view of a dissection that is done. When you have a coronal view in a radiologically, you can see this picture. You can see the optic nerves beneath. There's a internal carotid artery and a pituitary gland. So any infection, any inflammation, any vascular cause, any trauma, any neoplasm, any bone tumor, all these can cause compression. So let's see each of these one by one. An intracranial segment, this is what I'm showing you initially. So you can see that there is an optic chiasma right above, there is a pituitary stalk connecting, and the pituitary gland. Beside that, you can see the internal carotid artery that is coming, right? And therefore, for an optic chiasma directly to be involved, a glioma or a demyelination can cause, or a aneurysm of the internal carotid artery can cause a problem. A sphenoidal sinus issues like a squamous cell carcinoma can cause. Something coming from above, that is hypothalamus, causing a compression on the optic chiasma can cause damage. The cavernous sinus lesions, schwannoma, or a keratoconus fistula can cause a damage, or any problem with meninges, that is meningioma and inflammation can cause. So let's see each one case by case. So I had a case of a 67-year-old female. She came with a history of diminution of vision of both eyes since many months. Initially, she presented to the general ophthalm OPD. There was no history of trauma and history of difficulty in walking since 1 year. And there was a past history of some nasal surgery during childhood. Now, she was first initially referred from the general ophthalm to the glaucoma department because of the large size cup that the doctor observed. And in the glaucoma department, a gonioscopy was done, AC was found to be shallow, but IOP was on the normal side. But because there was a squint, she was referred to the squint clinic. So in the squint clinic, again, I take up all the full history of difficulty in walking is there still, and there's a past history of some nasal surgery done, but history of squint was not present in childhood. She gave me the history. It's present only since 1 year. So this is a picture. You can see there's large angle of left exotropia that is there. You can see on general physical examination, because of the nasal surgery, there's a saddle nose there, okay? So extraocular movements, you can see on the right side and left side, there is an adduction limitation in both eyes. And pupil, this is very important, pupil was round, regular reacting, but sluggish in reaction. So that is when something has to click to you, there is some problem. Cataract, there is a NS1 to 2 cataract. Fundus, you see, mild dyspallor, very difficult to detect, okay? And as we told, cupping was there around 0.6. Color vision was tested, it was normal. I got a fields done. You see a bitemporal hemianopia. You cannot miss that out, right? And an RNFL also showing that there is a thinning there. And an MRI shows a big figure of 8 cellular mass there, sitting right over there, okay? So this is something which cannot be missed, okay? So this was a case of what we call as a pituitary macroadenoma, okay? So the red flags here was a recent onset squint. There was a gait abnormality if you have taken a history properly. A pupil examination showed bilateral sluggish pupil, and fundus showed a temporal pallor in spite of having the cupping. Look at that carefully, okay? This is a case 2 of a 10-year-old child with a history of squinting present since 6 years of age and gradually progressing. The parents gave a history of hypoglycemia and bradycardia in the childhood, and she was seen elsewhere before 2 years back. Vision recorded at that time in the right eye was 636, in the left eye it was 612. Mild dyspallor was recorded in the previous report. A neuro opinion was advised. They didn't go. For 2 years, they have not gone anywhere. They sat right at home. And then they come here with a right exotropia to me. And there's a large left face turned to the child. And on recording the vision, now the vision is 660 in the right eye. Left eye it is 624. Pupil, again, you can see sluggish reaction OU. Color vision is normal, right eye. Left eye it is normal, right eye it is abnormal. And fundus shows a primary optic atrophy feature. And this is her HFA field. So you can see right eye there is an advanced field loss, and left eye there is a temporal hemianopia. So this is her RNFL and GCC. It's completely thinned out. Okay, and an MRI done shows that there is an adamantogenous type of craniopharyngioma. Okay, and that shouldn't have been missed out. She's been sitting here there since 3 to 4 years with that mass there. Now, this is a case 3 of a 20-year-old male. So this guy, he comes to the general ophthalmology OPD, and he's a differently abled child with a low IQ. You cannot rely upon his history completely. But he did give a history of sudden reduced vision in the right eye. No history of trauma or pain or anything of that sort. And vision recorded in the right eye in the general ophthalmology was hand movements, and left eye it is 6/9. Okay, they refer probably because he was not very cooperative. So whether it's reliable, the vision, we do not know. Okay, so pupil recorded in the OPD was like it was sluggish, and fundus was normal. They suspected a malingering. Okay, and when they came to a squint clinic, I took the history again. History of hypoxia, hypoglycemia is present at birth. There is a speech therapy issue. There is a delay development. So my mind, I was thinking about CVI features and all that. Okay, vision, but why vision sudden loss? If you rely on the history, hand movements, still hand movements, left 6/9. So pupil, there was a grade 1 RAPD, not very much, and extraocular movements full. And color vision, I tried with the tracing method because you cannot rely on his history, a tracing method for the Ishihara chart. And it was supposedly normal in the left eye, right eye because of hand movements, I couldn't check. Fundus was normal, literally normal, except for slight amount of pigmentation on the right disc. And confrontation was not cooperative, so I did a field test with the Berams. This is the old one. Okay, field, I do not know whether he will be cooperative. So you can see that in the right side field, there is some field loss that is there. Somehow he cooperated for that. And I did an MRI after that. It was a exophytic atypical pituitary adenoma, and it came out to be a pituitary, an apoplexy in the pituitary macroadenoma, and his hormone levels also were very high. So the points that I learned was that a large cup may not always be glaucoma. A gradual loss of vision indicates that it is a slow-growing tumor. Vision 6/6 may not always be normal. You have to be careful. Squint evaluation has to be done very carefully. HFA is mandatory for the normal eye as well. And pupil, you may not have RAPD if both eyes are affected symmetrically. And OCT RNFL can help as a prognostic factor. Okay, and this is just to go through it. This is a case of leash nodules with neurofibromatosis. And you have to remember optic nerve glioma that is common in neurofibromatosis. So how do you differentiate a meningioma and glioma? You can see that in glioma there will be a kinking of the optic nerve. Okay. A meningioma, what you can see is you can see sheathing along the optic nerve. So pearls here is, if the lesion is more anterior, as I told, there will be a true disc edema. Posterior only is the problem. And posteriorly, you can detect if there is an RAPD, but there may not be proptosis, and look for the disc carefully, and visual field is diagnostic. Okay, intracanalicular part I've already told, difficult to detect, and not the most common thyroid eye disease that cannot be missed because of this amount of proptosis if it presents like this. Okay, thank you one and all.
Thank you, Dr. Soumya, for that wonderful illustrative presentations of the cases as well as the anatomy. Wonderful illustrations.
Thank you, ma'am. Next, I request Leila ma'am. She is the HOD of Pediatric Ophthalmology, Comtrust Hospital, Calicut. She will be talking about hereditary optic neuropathies. Hereditary optic neuropathies is quite rare, okay, but you shouldn't miss that out. So that is the importance of including that in the session.
Thank you, Dr. Soumya, for giving me this opportunity. Actually, I'm happy to see the hall full. Lot of people were standing at the back without seats. So, with a very important topic, but it's not very common to see all these cases, many which come with dilemmas of diagnosis. So, clinical approach to hereditary optic neuropathies, which is not very commonly seen. They are inherited optic nerve dysfunction due to mutations, autosomal dominant or recessive or mitochondrial genomic mutations. A common feature is mitochondrial dysfunction or mitochondriopathy as we call. And retinal ganglion cells are vulnerable to mitochondrial dysfunction, which when triggered causes axonal degeneration leading to retinal ganglion cell death and vision loss. Main non-syndromic optic neuropathies are autosomal dominant optic neuropathy named after Jur and maternally inherited Leber's hereditary optic neuropathy. They are diagnosed by their inheritance, either clinically by the family history which we get or genetically. Clinical presentation even within the families are variable. And so genetic testing is the definitive diagnosis, especially in atypical cases. These are the hereditary optic neuropathies. Either the nuclear DNA may be involved, or as in Leber's, it is a mitochondrial DNA maternally inherited, or the DID-MOAD, which is diabetes insipidus, diabetes mellitus, and optic atrophy deafness syndrome, which was thought to be mitochondrial, but now it has been seen to be the reticular endoplasm which is involved. So the dominant optic atrophy is not so uncommon optic nerve degeneration, ranging from about 1 in 50,000 to 1 in 10,000 in Denmark, where it was diagnosed for the first time, with a penetrance of 70 to 100%. It is named after Jur, who found it in about 19 Danish families for the first time. It's a bilateral optic atrophy with a slow, insidious, defective vision in school-going age. Usually they present during the first decade. And they don't point out when it started. You check vision is down, and you see slowly progressing optic atrophy. And patients, the mutations occur in nuclear OPA1 gene located on chromosome 3q28 to 29, which plays a major role in mitochondrial dynamics. OPA1 encodes for mitochondrial membrane biogenesis and stabilization of membrane integrity, and abnormal mitochondrial metabolism and impaired oxidative phosphorylation leads to this retinal ganglion cell death and optic atrophy. So, a lot of functional, structural, and electrophysiologic tests can be seen. Color vision defects show a generalized dyschromatopsia, more in the blue-yellow spectrum, unlike most of the optic nerve diseases. Central, centrocecal, or paracentral defects, as we have already seen, like as in optic neuritis. And OCT shows temporal RNFL thinning with predominant loss of RGC in temporal quadrant, and OCT angiogram in the recent years have shown reduced blood flow in the temporal region of optic disc. And BEP shows reduced amplitudes and prolonged latencies, as we see in optic nerve disease, and pattern ERG shows reduced N95 components. So DOA plus dominant optic atrophy with combined other manifestations of sensory neural hearing loss, myopathy, peripheral neuropathy is called DOA plus, and treatment. The pharmacological neuroprotection, generally addressing antioxidants to reduce the oxidative stress, to slow damage to the retinal ganglion cells, idebenone, which is FDA approved for Leber's, has been used even for dominant atrophy, and gene therapy aimed at halting neurodegeneration has been tried, and cell-based regenerative therapies also have been tried but of not use. So coming to Leber's hereditary optic atrophy, though first described by Leber in 1871, the mitochondrial inheritance was shown only in 1980s. Its first inherited disease identified to be due to a point mutation in maternal DNA, mitochondrial DNA, and is the commonest mitochondrial maternally inherited disease. And the prevalence is 1 in 100,000 persons with a male predominance of 90%. And it is due to the maternally inherited mitochondrial DNA point mutations. And this is the commonest inheritance point mutations seen at 1177.8 A, G to A. That is the commonest mutation seen in about 70%, and the other mutations, which is the commonest, reported globally. But there are about 50 point mutations seen. Only 50% of the males and 10% of females they develop the optic neuropathy. That means there is an incomplete penetrance. Not all the patients develop the disease. It starts during the second or third decade and with an acute or subacute painless vision loss, followed weeks later by the other eye also getting involved, and rarely the other extraocular manifestations, which is called LHON plus, can be there. And like in optic neuritis, Uthoff's phenomenon may be there, and so optic neuritis is diagnosed. And it is characterized by three major phases: the asymptomatic acute phase with some fundus picture showing circumpapillary vessel tortuosity and telangiectatic capillary microangiopathy, and OCT may show an edema of the disc due to the axoplasmic flow stasis and edema, and the papillomacular bundle area may show some thickening. And in acute phase, that is when there is sudden loss of vision and the fundus shows the classic triad of circumpapillary telangiectatic microangiopathy, swelling around the disc, and thickening of the RNFL. And with the lack of leakage in FFA, 50% may look normal also, and OCT shows RNFL thickening around the disc except temporally. And MRI may show an optic nerve enlargement but may be normal, and so we may make a diagnosis of optic neuritis. Often the same picture as an optic neuritis, color vision may be affected, central or centrocecal scotomas, and pupil may not show a big RAPD. And after 3 months, temporal pallor may be seen. After 6 months, it may be a total pallor optic atrophy. And optic MRI shows a volume loss of the optic nerve also. And vision loss is profound and permanent. And there are some triggering triggers like smoking, heavy alcohol consumption, and exposure to toxic drugs. So we have a 16-year-old boy who presented with sudden loss of vision in right eye. His vision was 660/66. Fundus showed mild hyperemia and showed the typical field changes of optic neuritis. VEP showed latency. MRI was normal. And he was given, diagnosing as an optic neuritis, he was given methylprednisolone followed by oral steroids, as already pointed out by Dr. Ramya, the regular optic neuritis regimen. And after 2 weeks, his vision, even while he was on steroids, deteriorated in the other eye. And both eyes had about few meters, 360, 260. And on detailed questioning, a family history of vision loss in childhood in his maternal family members was there. So this boy was about 17 years. He appeared for exams with the help of a scribe for the next 2 years, but his vision started improving after a year to 6.9, 6.6 finally after 2 years, and his vision field also got improved. Later, we did a molecular analysis which showed mutations in ND1, ND4, ND6 with totally different mutations, point mutations seen in totally different points, genes. So, so we have to know more about this disease. It is often mistaken for optic neuritis, and they may be diagnosed as toxic optic neuropathy, nutritional optic neuropathy. Treatment, as we have already seen, the rescue of hereditary optic disease of outpatient study RODOS showed that Idebenone is a safe drug, and it is FDA approved to be started within 6 months of onset of the visual loss. And it is an electron carrier transferring electrons directly from mitochondrial complex 3 to the diseased complex 1, reactivating the RGCs. And a lot of studies are there for gene therapy. In 2017, the rescue and reverse clinical trials with adenovirus injected to intravitreally for this main mutation has been found successful. 15-letter improvement has been seen from PL. So the trials are going on, and other therapeutic trials are also there. So this Wolfram syndrome is now not considered a mitochondrial disease, but it is still inherited juvenile onset diabetes mellitus insipidus and deafness, and mutation of WFS1 gene confirms diagnosis. It has a poor prognosis with a lifespan of less than 30 years. And optic atrophy in a diabetic of less than 16 years should raise this suspicion. And diabetes usually occurs by 6 to 7 years, optic atrophy by about during the first decade, 10 to 12 years. Other symptoms are also there. So it's important to exclude primary retinal degenerations with optic disc pallor. Retinal findings may be subtle, and especially with the cone dystrophy with optic nerve pallor may be the early finding. But retinal artery attenuation, abnormal retinograph ERG may be helpful. So it is good to have a high index of suspicion in these cases with vision loss in childhood, and a family history should be sought. And modern imaging techniques may help in showing papillomacular bundle involvement, and clinical diagnosis is often possible with a family history, but definitive diagnosis is by gene mapping, and early Idebenone treatment is, as of now, the only treatment. So, thank you.
Thank you, Leila madam, for elaborating on this hereditary optic neuropathies, and it shows how much important a gene testing may be in certain cases also. And next we move on to the next session. It's on toxic optic neuropathy. I invite Dr. Dalia Krishna. She is a senior medical retina specialist from Shrikant Eye Hospital, Calicut.
Thank you, Dr. Soumya, for that opportunity. Good afternoon, all. So I would be sharing my insights on toxic optic neuropathy. So as the name suggests, toxic optic neuropathy refers to visual impairment due to optic nerve damage caused by a toxin, which may be a drug. So it typically presents with bilateral, painless, progressive, usually symmetrical visual loss, with changes in color vision. Here, the vision loss progresses over months rather than days. And on examination, there is no RAPD. The optic disc may be normal or swollen. Optic disc pallor appears later with central or centrocecal scotoma. So there are numerous drugs and toxins associated with optic neuropathy. Notable among them, the ATT first-line drugs, ethambutol and isoniazid, linezolid used for MDR tuberculosis, amiodarone, many anti-cancer drugs and immunomodulators are also implicated. Methanol causes an acute toxic optic neuropathy as an exception. The risk for toxic optic neuropathy increases when the drugs are used in high dose or prolonged duration in patients with renal and liver disease, old age, low weight, malnutrition, diabetes, substance use, and occupational exposure for a long period. Different substances affect the optic nerve in different ways, but the common pathway seems to be the mitochondrial injury with the imbalance of intracellular and extracellular free radical homeostasis. So thus, the toxic optic neuropathy is an acquired mitochondrial optic neuropathy similar to Leber's, as ma'am said. So for the diagnosis of optic neuropathy, the clinical history usually indicates the possible etiology. So toxic optic neuropathy, which has a slower course, has to be differentiated from compressive, infiltrative, nutritional, and hereditary optic neuropathy. To work up a case of toxic optic neuropathy, a detailed history, including the drug history and the toxin exposure and the risk factors I mentioned before, are very important. Ocular examination should have vision, color vision, contrast sensitivity, pupil, fundus examination, visual field testing, and OCT examination for RNFL and GCL thickness. Investigations, VEP is very important to confirm the optic neuropathy, and neuroimaging to rule out compressive optic nerve compression lesions. Blood tests, including liver and renal function test, rule out, and also syphilis serology is important. Specific tests for the specific toxins are required. Coming to ethambutol optic neuropathy, we are all seeing increased incidence of ethambutol optic neuropathy following the revised guidelines of RNTCP program, which allows for daily dose and longer duration of ethambutol use and fixed dose combinations where the number of tablets prescribed is based on the weight band of the patient. So studies have shown that the ethambutol related optic neuropathy increases with increasing dosage. So the patients with low birth weight, kidney disease, older age are at now higher risk for ethambutol optic neuropathy. And the toxicity typically appears between 3 to 5 months of age, but may present early or later. Presenting a case of ethambutol optic neuropathy where a 73-year-old male patient came with complaints of difficulty in reading for the past 2 weeks, on ATT for tuberculous pleural effusion for the past 4 months. On examination, pinhole visual acuity was around 612 in both eyes with defective color vision and decreased contrast sensitivity. No RAPD with nuclear cataract. Fundus was normal, but the perimeter revealed grossly decreased sensitivity with lot of defects. VEP was done, which showed decreased amplitude of waves, which was more severe in the left side. MRI brain with orbit was done, which is normal. So the chest physician was advised to stop ethambutol. So after stopping ethambutol, his visual field and the acuity improved over the next 3 months. But the visual acuity and the field improvement is very variable after stopping ethambutol, as seen in some of these patients. This is a 64-year-old man who came with ethambutol toxicity. After the stopping ethambutol, initially his vision actually deteriorated in the first 2 to 3 months and then improved over the next 7 months. In this 27-year-old male doctor who came, again the same deterioration the first 1 month and very slow improvement over the past next 2 years with some residual defects even after 2 years in the left eye. In this renal patient, over 6 months follow-up, not much of improvement. So to highlight the increasing incidence of ethambutol optic neuropathy, what are we doing? So Indian Neuro-Ophthalmic Society organized a meeting of leading experts in the field of neuro-ophthalmology, pulmonary medicine and pediatrics to create a consensus on possible advisory and examination schedule to pick up early toxicity. The consensus was on clinical presentation diagnosis, screening and primary prevention with special recommendations to physicians and ophthalmologists, treatment and reporting of adequate reporting of ethambutol toxicity. Coming to isoniazid optic neuropathy, which presents with bilateral optic disc swelling and bitemporal hemianopic scotoma. So in a patient on ATT, if the vision loss is progressing even after stopping ethambutol, INH has to be stopped. Next, coming to linezolid optic neuropathy, which is seen in patients on multi-drug resistant tuberculosis. Here it is recommended that frequent visual function monitoring should be done if the linezolid is being given for more than 28 days. Sharing one of my cases where a 51-year-old male patient with history of defective vision of 1 month duration, known diabetic, on treatment for multi-drug resistant tuberculosis past 18 months, was on linezolid for the past 6 months with other second-line drugs. INH and ethambutol was stopped 9 months back. So after his visual acuity, color vision and visual fields were found abnormal, linezolid was stopped, showed a good improvement over the 4 months period with the baseline visual acuity achieved after 4 months. Coming to amiodarone optic neuropathy, presents with very slowly progressing binocular loss of vision. Very important point is you have prolonged disc swelling, and these patients on amiodarone therapy also have the same risk factors as the patients of non-arthritic AUN, so needs to be differentiated. And the points in favor of amiodarone is it's an insidious onset, as non-arthritic AUN is the acute unilateral visual loss as presented before. The resolution of disc edema in NAN is over weeks, whereas in amiodarone it is protracted for months, it may stay. And NAN has the crowded disc in the other eye. Coming to methanol toxic optic neuropathy, which is one of the causes for acute optic neuropathy, not an insidious loss. usually found in cases of ingestion of adulterate alcohol contaminated with hooch. The visual loss usually is seen after 12 to 24 hours. Diagnosis confirmed with the serum ethanol levels, and treatment of methanol poisoning is advised. Before I summarize, I want to share this case of an 89-year-old doctor brought by doctor's son, not able to read newspaper since past 1 month, diabetic, hypertensive, and cardiac patient on treatment. On examination, his visual acuity was 6/60 in the right eye, 4/6 in the left eye. Pupils were reacting. Fundus showed moderate NPDR in both eyes. Confrontation fields were not showing any hemianopia. OCT macula was done, which showed a mild DME in the left eye. So, not finding a clue, I sent for a neurological consultation with neuroimaging to rule out any cortical cause for slow visual deterioration. 2 weeks later, I got a call from one of my beloved teachers saying that the doctor's son had forgotten to tell me that he was in ATD for the past 4 months. So a thorough history is so crucial to making a diagnosis. So to summarize, treatment of toxic optic neuropathy does not always yield fruitful results. Prevention is the key with baseline evaluation before starting treatment. Early detection can salvage vision. Asking for specific drug history in all cases of insidious visual loss, very important. Stopping the offending agent is the only treatment option, and proper follow-up and testing can help toxicity early. Thank you. I take this opportunity to invite you all to Ignite 2025, which will be held in Kochi on January 4th and 5th. Thank you.
Thank you, Dr. Dahlia, for that wonderful talk covering all the toxic neuropathies and highlighting the importance of histories. History and clinical examination still holds good in, especially in neurology and neurophthalmology. I think we cannot give up. Definitely imaging and other high-tech investigations do give us a nudge for diagnosis, but definitely history and clinical examination has a very big role in coming to a diagnosis in neurophthalmology.
I second the thoughts with which ma'am has. So next we move on to the next session on traumatic optic neuropathy. I invite Dr. Anita Prabhakaran. She's a pediatric ophthalmologist from Precise Hospital, Trivandrum. Over to you, Dr. Anita.
A very good afternoon to one and all, and thanking for the opportunity. Let us deal with the next sector of optic neuropathy, so which is related to trauma. Whenever I hear this topic, I get vivid thoughts, vivid memories of a teenage boy coming to our OPD when I was doing my second year PG way back in 1998 in Madurai Medical College. He had presented with diminution of vision in one eye, and he had features of optic atrophy. On detailed history taking, he denied any history of trauma to the eye, but on repeated questioning, he remembered that he had sustained some trauma to the forehead, just above at the supraorbital region. He had some trauma to the forehead, and both he and we PGs were quite upset that we had no treatment to offer as well. It was Hippocrates who first described the term traumatic optic neuropathy in closed head trauma patients, and by definition it is any insult to the optic nerve secondary to trauma. Either it could be a direct trauma to the causing damage to the optic nerve, or it could be an indirect trauma where the deformative stress will cause is concentrated on the optic canal area, and depending on the site of injury also it is classified, and the most commonest lesion is at the intracanalicular part. So as we can see here, when there is a direct traumatic optic neuropathy, there could be a projectile or some kind of a trauma which causes significant anatomical disruption of the optic nerve, leading on to optic nerve avulsion, transection, optic nerve hematoma, and the like. And here the patient presents with severe visual loss and the poor almost NLP, and the visual prognosis is also very poor. Whereas in indirect traumatic optic neuropathy, it's a mechanical impact. The injury is actually from a distant site, and there is no overt damage to the surrounding structures. But because of the dural sheath is tightly adherent to the periosteum at the intracanalicular segment, that is the most susceptible, followed by the intracranial portion where there is a close proximity to the falciform dural fold. So why does this happen? There is actually a primary and a secondary injury going on. So that's a two-stage model theory, where the first, what happens is a shearing of the ganglion cells and interruption of the blood vessels. And that causes ischemia and optic nerve swelling, which leads on to a compartment syndrome. And this pressure effect will cause an apoptosis, which will continue as a vicious cycle. So that is where the role of decompression comes in. And the biomechanics was tried to be explained with a computational head model, which showed that this 45-degree injury, trivial injury, is to the frontal area, to the supraorbital area, is more likely to cause a traumatic optic neuropathy, which explains the boy which we had seen. So clinically, we need to get a detailed history of the trauma and to look at features of optic neuropathy and any other associated injury to the orbit and the adnexa. So usually it could be unilateral or bilateral. There could be present, RAPD is the pathognomonic finding of traumatic optic neuropathy. If there's no RAPD, it's either it's not a traumatic optic neuropathy or it is a bilateral optic TON. And the vision loss can be variable. It could be more rapid than that seen in the toxic and compressive type. Of course, color vision and visual fields will be defective as in optic nerve involvement. If the injury is anterior to the point of entry of central retinal vessels, you can see some hemorrhages with optic disc swelling. But if it is posterior, the fundus will be normal. It takes about 6 weeks for optic atrophy to set in. How would you manage? First, we talk about investigations as usual. But here, we know that to demonstrate optic nerve sheath hematoma, optic canal fracture with the bone impinging on the optic nerve, we need to have some neuroimaging. And the argument is that the neuroimaging should be done at the earliest, so that if there is any bone fragment, it has to be surgically removed to. But the counter argument is that irrespective of the treatment modality, there is no, the visual recovery, very poor prognostic factor for visual recovery. Hence, right from the investigation till the management, I will be continuing to speak about, continuing to remember Shakespeare's quote of to be or not to be, because neuroimaging is again a questionable. The clinical usefulness of neuroimaging in traumatic optic neuropathy is not been, it remains debatable, as there is no consistent correlation between the presence of a fracture or location of a fracture with the severity of visual loss or a visual recovery prognosis as well. So whether it should be done for all cases or only those which are progressing or those which needs intervention is still questionable. And which modality? CT is the best modality to delineate the optic canal lesions, and whenever you do an MRI, make sure first you're doing an X-ray to rule out a metal intraocular foreign body. And coming to the management, as we said, indirect traumatic optic neuropathy, because it's a very severe irreversible visual loss and no intervention is of any proven benefit, whereas in indirect traumatic optic neuropathy as well, there are no confirmed protocols for prevention, mitigation or treatment. The main stay of treatment includes steroids, surgical decompression, a combination of these two, or observation. But of course, we need to remember to rule out a possibility of retrobulbar hemorrhage and to watch for development of optic nerve sheath hematoma, where we'll have to relieve the pressure by head and elevation, tapped IMOX, and if at all needed, a lateral canthotomy as well. So there were studies on acute spinal cord injury where they gave steroids within the first 8 hours, and they found significant improvement in the neurological functions. And that was the basis of giving steroids in optic neuropathy as well. And the steroids which are given are very high dosages, which are even mega dosages. But no significant difference was found in the final visual outcome, even with higher dose of steroids or with an earlier initiation of treatment. At the same time, there were serious systemic complications and more mortality in patients who were treated with steroids, especially in people with predisposing factors. One more thing is, instead of the benefit, there was some adverse effects was found, and which exacerbated the retinal ganglion cell loss as well. And regarding the surgical options, we have the intra or the extracranial or endoscopic optic nerve decompression. Again, the timing is controversial, whether you should do it immediately to salvage the ganglion cells, but there is conflicting evidence that there is no difference between whether you do it immediately or not. There is no impact on visual recovery. And on the effectiveness of surgical decompression as well, there are no RCTs. So and here also we have to consider the very potentially serious complications like CSF leak, meningitis and accidental dural exposure. So we want to draw your attention to this largest prospective multicentral trial of traumatic optic neuropathy which was ever published, and here it's very clearly seen that it is the observational group which has the maximum visual recovery when compared to the interventional groups. So we can only predict the prognosis. That is the most important predictive value is a visual acuity at presentation, and any lack of visual recovery after 48 hours, even after steroids, is a poor prognosis. Other poor prognostic factors are loss of consciousness, age over 40 years, high grade of RAPD and absent visual evoked response, and lower the flash VEP amplitude, lower the latency, worse the prognosis, and presence of blood within the post-ethmoidal cells and an OCTA showing poor inner retinal capillary density are all poor prognostic factors. There are some studies still going on. Some results have been published, which is known as a traumatic optic neuropathy treatment trial, where they have tried erythropoietin and levodopa plus carbidopa along with steroids and compared it with observation. It started in February 2011. Still some part it is going on, but as much as the results are published, it is promising because there is some improvement in color vision and RAPD, but the final visual recovery is still the same. So the practical considerations, there is a narrow window for initiating the treatment, and because of other life-threatening injuries, there is an unavoidable delay in diagnosing the traumatic optic neuropathy. With the relatively high rate of spontaneous visual recovery and no convincing evidence that steroids or surgery provides any additional benefits, to subject a patient to these potentially complicating interventions has to be considered with caution, and any decision taken as per the best interest of the patient. Thank you very much.
Thank you, Dr. Anita, for the wonderful talk. So basically, to summarize, always and always take a detailed history. That is the most important, I think, what we have seen in all these sessions. Okay, the history is the important. At least 80% of diagnosis can be made with your history. Look at the pupil. Examine the pupil properly. Okay, so a sluggish pupil, a grade 1 RAPD should not be missed out. And look at the fundus, I think, very carefully. A disc edema, in spite if there is no disc edema, because by the time the pallor comes, the time is vision. So the later you're going to refer the patient or later you're going to diagnose, you have lost that much amount of vision. So I think you have to have a careful examination of the patient as such. And you don't have a visual field, at least do a confrontation for the patient. Okay, so visual field is not mandatory. VEP is not mandatory to diagnose this. You shouldn't be missing out anything. That is the basic criteria. And never err. Like you are thinking that whether to do an MRI or not. I think today's world, medico-legal issues are so common. Okay, you need to diagnose the patient as and when you find it and properly. Okay, so documentation is also very, very important, especially in cases of this traumatic optic neuropathy. Though maybe the treatments are not going to be very favorable, but at least you can document that you have done this and that, and maybe the vision has not improved in spite of doing that. That is what I would like to add. Any questions? I think you can ask.
Legal aspects apart, I would like to just highlight the case of a boy in the 20s who had a very bad RTA with the, I think he had a tracheostomy and everything with Dr. Naina had seen the patient, and he was, he had only few meters of vision after 1 month after trauma. And of course, steroids in an older patient with comorbidities, we have to take a lot of precautions in starting steroids. But we gave the benefit of doubt and started him on steroids because his vision was very low, and he was recovering from a 6th nerve palsy also. And he recovered to, I think, 6/9. Vision was surprising. So neurological problems after a trauma is very unpredictable. So sometimes we have to decide by a case by case. We have to decide whether, is the next session starting? Okay, I think.